Hello, can you hear me? Okay, and have we begun recording? Have we begun the recording? Okay. Pardon? Okay. So hello, my name's Ria. I am one of the foundation doctors at the Royal London Hospital. Today I will be discussing the role of contraception and counselling for contraception, in particular for OSCE. So when it comes to contraception, the objectives of this lecture will be to understand and to formulate a contraception history, to understand the various methods of contraception, and to understand the mechanism of action of each method, and to explain the method of use, the side effects, and the contraindications of each method. So prior to beginning your OSCE station, it's obviously important to first introduce yourself and to get the name and the date of birth of the patient. It is most appropriate to reassure the patient about confidentiality and then to establish a rapport with the patient to begin the contraception history. So when taking a contraception history, it's important first to get the patient demographics. So you need to know the age of the patient, and I will later go on to the importance of clarifying the age of the patient. Second, it's important to get sexual history. So when taking a sexual history, it's important to ask about single partner or multiple partners, any past or present relationships, and when their last cervical smear was, the results of the smear, and if the tests were abnormal, and if the patient's on any management for the smear. Secondly, it's important to get a menstrual history. So when discussing a menstrual history, you need to note the day of the last menstrual period, the frequency and duration of menses, and if their cycle is regular or irregular. You want to ask questions regarding dysmenorrhea and menorrhagia. And when coming to an obstetric history, you want to ask about recent pregnancy, history of any infertility, any IVF or previous miscarriages, and breastfeeding. Again, I will highlight later why the importance of asking these questions when deciding to individualize contraception for a patient. Okay, so as you continue to take a contraception history, it's important to ask about past medical history, drug history, social history, and family history. In particular, for past medical history, it's important for you to ask about breast or cervical cancer and any previous VTE, so if they've had any previous clots, and if they have had any previous migraines with aura or any STIs. For drug history, it's important to ask about previous contraception and obviously getting more details about the previous contraception, what worked and did not work, and any allergies to any medications. It's also important here to ask about any copper allergy, in particular use to the copper coil. For social history, it's important to get their smoking history, as some contraception medications are contraindicated with smoking. And again, like past medical history, it's important to gain a family history about breast, cervical cancer, VTE, and a migraine with aura. If you do need to get examination during your OSCE station, it's important to get the patient's blood pressure, weight, and height. This may come across in an OSCE station as a question at the end of the station, asking what further investigations or examination will you need prior to prescribing a contraception. And that's when you do need to measure the blood pressure, weight and height to calculate a BMI, as some contraceptions are contraindicated for various BMIs. The next thing you want to do after getting a contraception history is to make sure that you're individualizing the management for the patient. You want to, at this point, get their ideas, concerns, and expectations. You want to ask them what they're hoping to get out of this consultation and what they know so far about any contraception. You want to also determine what's the most appropriate method for the patient. So it's important to ask about any preferences for any contraception, a preferred delivery in terms of a pill, a patch, ring, injection, and or an intrauterine device. And you want to ask them their ability to remember to take medications on a regular basis. The next thing you want to do is, once you've formulated what their ideas, expectations, and concerns are, and if they have any preferences, at the background in your mind, you should be thinking about your contraception methods and those available to you. So the various contraception methods include barrier protection, a contraceptive pill, of which a combined oral contraceptive pill or a progesterone only pill. There's coils, patches or rings, implants and injections, and intrauterine contraception, which includes an IUD or an IUS. So when counseling a patient on a contraceptive method, you want to explain, 1, how it works, 2, the treatment course and the method of use. You want to cover the side effects and risks associated with each contraception method, and you want to explain the positives and negatives of each contraception method. So I will now be explaining and going into each contraception method and explaining these 4 elements in relation to each method. So the first method I want to explain is barrier methods. As we know, there are 3 different types of barrier methods. There's condoms, diaphragms, and caps. The mechanism of action, or how it works, is that you want to explain that it prevents the sperm from entering the cervix. As you know, condoms, advantages are they're readily available. They protect against STIs. Disadvantages are the allergy, although they are latex-free available, and also the risks associated with condom use are breakage of the condoms and the effectiveness of condoms. The second barrier method is a diaphragm. So a diaphragm normally lies diagonally across the cervix. So this picture displays a diaphragm. The advantage of a diaphragm is that it holds the sperm in the acidic environment of the vagina. In addition, you can use a spermicidal gel and place it inside the diaphragm and then be put in the cervix as a additional agent and barrier. And disadvantages of a diaphragm is that it needs correct fitting and it does not completely occlude the passage of sperm into the cervix. And the third method is a cap, and it fits across the cervix. So now I will be explaining about combined oral contraceptive methods. So when explaining different examples of a contraceptive combined oral contraceptive methods. You have second generation and fourth generation medications. So second generation medications are microgynon. Third generation are Yasmin or Celeste, and your fourth generation are your Glarias. It's important to perhaps know at least one example of each generation for a combined oral contraceptive method pill. So you want to explain that a combined oral contraceptive pill has both combined estrogen and progesterone. It's the most commonly used contraception, and your failure rate is in perfect use is 0.1%, but averages at 8% with basically when you consider missed pills, when you consider use with other medications. So I wanted to explain the mechanism of action of your combined oral contraceptive pill, and I have brought in a menstrual cycle and the hypothalamus pituitary gonadal axis to explain the method of action. Obviously, this is just for your fundamental learning and knowing exactly how the combined oral contraceptive pills work. So, as you know, in oral contraceptive mechanisms work in the luteal stage, which over here is highlighted by the number 3. So, normally, if we go back to the follicular phase, and the menstrual cycle, as you know, the hypothalamus releases GnRH, which acts on the anterior pituitary. Anterior pituitary then releases LH and FSH. LH works on the gonads in the ovary, and that's the theca interna cells, and FSH works on the granulosa cells in the ovary. In turn, the ovary then produces estrogen and inhibin. So at low or intermediate levels of estrogen in the follicular phase, the estrogen acts as a negative feedback mechanism to the hypothalamus and the anterior pituitary. When you're talking about ovulation, which typically in a 28-day cycle would roughly occur between on day 14, in order to know how this mechanism works, at high concentrations of estrogen then acts as a positive feedback mechanism to the anterior pituitary and the hypothalamus, and therefore you create this LH surge, which is basically happens in ovulation. So it's important to know that as the follicle grows from day 1 to day 14, it basically secretes more and more estrogen as the follicle grows. As the follicle grows, it produces more estrogen, and when you have high concentration of estrogen, it then acts as a positive feedback mechanism, creating that LH surge. In turn, you know that inhibin inhibits FSH, and therefore you have a LH surge, but your FSH is controlled. But what's important in combined oral contraceptive mechanisms is how they act on the luteal stage. So in the luteal stage, as you know, you'll have the corpus luteum, and you have LH and FSH acting basically released by the anterior pituitary. LH then acts on the corpus luteum to produce estrogen and progesterone. The mechanism of action of your oral contraceptive methods is that progesterone prevents estrogen. So progesterone prevents high concentration from estrogen from basically on the hypothalamus to reduce the frequency of GnRH pulses, and also inhibits FSH, which therefore prevents any new follicles from developing. So when talking about combined oral contraceptive methods, to highlight, Progesterone acts on the HPG axis and decreases the frequency of GnRH pulses and the follicular development by inhibiting FSH. And estrogen also acts on a negative feedback on the anterior pituitary and basically decreases your LH, which leads to no LH surge. It's also important to highlight that progesterone, as its main action mechanism, is to basically thicken the cervical mucus and acts as a hostile environment, preventing sperm from entering the uterus. So when explaining the method of use to your patient, ideally you would start on day 1 of the cycle. You take it for 3 weeks, and you take a 1 week pill-free week, which is where you have your withdrawal bleed. If you do start it not on your day 1, you would advise for 7 days condom use alongside starting the oral contraceptive method. You want to make sure that you're able to explain the side effects of your combined oral contraceptive method. And I like to break it down into both estrogen and your progesterone side effects. So in terms of estrogen, you're going to have breast tenderness, some nausea, some cyclical weight gain, bloating, and vaginal discharge. And for your progesterone side effects, these include mood swings, premenstrual tension, vaginal dryness, sustained weight gain, decreased libido, and acne. And other side effects include headaches. And when talking about absolute contraindications, the importance of gaining a contraceptive history, as mentioned earlier in the lecture, was to highlight whether your patient's social history, if they were smokers, and again, confirming the age and date of birth for these contraindications. So absolute contraindications for combined oral contraceptive methods include smokers greater than 35 years old, less than 6 weeks postpartum, if they're breastfeeding, if they have hypertension, and that's why it's important to gain a blood pressure, current or past history of any blood clots, migraine with an aura. So if they do have or suffer from a migraine and they have no associated aura, it is not a contraindication. And if they've had current breast cancer, liver cirrhosis, and or cerebrovascular disease. Relative contraindications include controlled hypertension, migraine greater than 30, a migraine above the age of 35, a BMI of greater than 35, and if you're taking any enzyme-inducing medications, it's important to take that history from your drug history. Okay, so when taking or advising a patient for a combined oral contraceptive method, it's always important to mention about missed pills. You want to advise them to take, if they have missed a pill, to take the missed pill as soon as possible, even if it's with the next pill. If they miss 2 pills in a row, you want to advise them to take 1 pill immediately, in addition to 7 days condom use, and further management depends on the week of which they have missed that pill. So it's important to note that for your 7 days, your first 7 days of contraception, that is what prevents ovulation, and the rest of the 21 days is to maintain an ovulation. And that's why these weeks come into play. So if you miss your first week packet, you need emergency contraception if they have had sex in their pill-free interval. If they've missed their pill on their second week, then no actions required. And on the third week, tell them to omit their pill-free week and to continue on that cycle to the next month. If your patient has had diarrhea or vomiting and or any enzyme-inducing drugs, you want to tell them to have 7 days condom rule. So the positives of contraception, of the combined contraceptive pill, is that it controls periods and bleeding and pain. The next method I want to highlight is your progesterone-only pill. Again, you want to explain the mechanism of action. Progesterone, as we know, basically thickens the cervical mucus, creating a hostile environment, and reduces the receptivity of the endometrium to basically implantation. And again, it works on the HPG axis by inhibiting ovulation. The method of use for the progesterone-only pill is to take every day with no pill-free week. Ideally, you start on day 1 to 5 or any other time with 2 days of condom protection. And it's important and vital to mention that they must remember to take the progesterone-only pill every day at the exact same time. And that's why, again, highlighting in your contraception history to note what their tendency is to take medications regularly at the same time. Contraindications to your mini pill or progesterone-only pill is breast cancer, PV bleeding, or liver disease. Again, you want to mention your progesterone side effects, which are the same as we've previously highlighted, and other side effects include headaches, irregular bleeding, increased failure rate compared to the combined oral contraceptive pill. You want to highlight if they've had any missed pills to take their pill as soon as possible, even if it was the next one. But if they are 3 hours late, you want to basically use condom for 2 days and consider the emergency contraceptive pill if they've had sex in 2 to 3 days. Next, I want to talk about the contraceptive patch. So the contraceptive patch is a combined oral contraceptive, and the name of the contraceptive patch is Evra. You want to talk about basically the patch in patients who do not like taking oral basically oral medications. And in terms of a patch, it's apply a patch on day 1, change on days 8 and day 15, and remove on day 22, and then again reapply a patch for after 7 days of the patch-free interval. I won't explain the mechanism of action because it's a combined oral contraceptive, and the side effects and the are similar. You then want to basically know about a vaginal ring. Again, a vaginal ring is a combined oral contraceptive pill, and of note, it's called Nuva ring. A Nuva ring, basically, it's a flexible ring which releases both ethinyl estradiol and ethanogestrel. You insert the ring into the vagina on day 1 of the cycle, leave it for 3 weeks, and again removed on day 2, and you have 7 days ring-free interval. So as you can see, the method of use for combined oral contraception is the same. The next method I want to explain is the progesterone injection. So the progesterone injection is Depo-Provera. Okay. The mechanism of action, as explained, thickens the cervical mucus, inhibits the sperm penetration. Method of use is basically given every 12 weeks, and you start on the first 5 days of your cycle. So as you can tell, it lasts for 3 months. You obviously have the same hormonal side effects. And in terms of your period, they can basically become irregular. They could actually be prolonged and or stop entirely. In terms of the contraindications, it's important to note that age, if you're less than 18 or greater than 40, it's an absolute contraindication due to the risk of osteoporosis. And if they do have osteoporosis, you basically want to prevent the use of the progesterone injection. The negatives of the progesterone injection is the fact that they have to make sure that they come back to clinic every 3 months to get the injection. And once obviously given, it cannot be removed. So your side effects may last for the period of 3 months. Another negative of the progesterone injection is the fact that if stopping the progesterone injection, it actually does take time for fertility to return and could be as long as 3 months post stopping the injection. Again, you want to highlight the benefits of it in terms of patients who do not adhere to oral medications regularly, and in that sense, for 3 months, do not have to worry about taking the medication. So let's talk about the contraceptive implant. So in terms of the contraceptive implant, this is a progesterone implant. So it's called Nexplanon. So method of use, it's a 3-year progesterone only releasing rod inserted under the skin of the upper arm. And normally you would have local anesthetic being put in, and then they basically insert the progesterone only releasing rod. And typically it would be inserted on day 1 to 5 of your cycle, or at any other time, but with 7 days of condom use. Again, the benefits of this, it lasts 3 years. You then obviously can forget about it. And the negatives include some patients continue to have unpredicted spotting with the implant. And obviously, in terms of negatives, it does basically require an incision, and you can feel that incision with the use of local anesthetic to aid that. The next mechanism I want to speak about is the intrauterine contraception. So intrauterine contraception includes IUDs and IUSs. IUDs is an intrauterine device, which is also known as the copper coil. In terms of the copper coil, the mechanism of action, obviously, it has no hormones. Copper acts as a toxin to the ovum and the sperm and inhibits the sperm from penetrating the cervix. And it inhibits fertilization. So the method of use is that it lasts for 10 years, and Side effects for the copper coil is that it has obviously the benefits is that it has no hormones, so you have no hormonal side effects. However, you can have heavier and more painful periods, again highlighting the importance of the contraception history, talking about their menstrual history in particular. Contraindications to the IUD is pelvic infection. You can also get a PID. So if you've had PID in the preceding 3 months, it's contraindicated. Gynecological cancers, PV bleeding, and of course a copper allergy. So when talking about the copper coil, you want to make sure that you highlight to your patient to always check for a string monthly, and that they can still feel the strings. You need to have an STI check before inserting the copper coil. And again, it can be put in any time. If you have not had sex since your period, or within the first 5 days of starting your period. Okay. The next method I want to explain is the IUS, which also is known as the Mirena, and they also have basically the JDS, which is of recently, I believe, their last 5 to 10 years. Mechanism of action, it's a progesterone impregnated coil, and therefore increases the cervical mucus, thins the endometrium, decreases the probability of implantation. Your Mirena is licensed for 5 years, and your JDS is licensed for 3 years. And side effects associated with the IUS is spotting for the first 6 months. Additional use, the Mirena, as you know, has beneficial use in premenstrual tension. If a patient has menorrhagia, Mirena is actually known to make your periods less heavy, and it's also given in patients who have endometriosis, and it also forms part of an HRT regimen. Contraindications, again, are the similar to previously mentioned of any intrauterine device. So those are the methods that you basically you need to explain